Good afternoon. So time to get start on this next symposium. Welcome to the symposium entitled Fast Track Cities Ending AIDS in High HIV Burden Cities and Municipalities by 2030. My name is Prapan Panupak. I'm the director of Thai Red Cross AIDS Center. I'm co-chairing this session together with my dear friend Jose Zuniga, the president or the executive director of IAPAC, the International AIDS Providers in AIDS Care. I think in almost every country, HIV burden is higher or much higher in large cities or municipalities. For example, in Bangkok itself, over 30% of the new infections happening in Bangkok. So if we can reduce the HIV burden in the large cities quickly, effectively enough, then we probably can do the same things in the smaller cities. Then the HIV problem in the country would then be reduced greatly. So focusing on HIV in the large cities is a major issue of ending AIDS here. I remember that Michel Sidibe, when he first visited Thailand for his first official visit in late 2011, I told him that the Thai Red Cross AIDS Center is going to do test and treat among MSM and transgenders in Bangkok. That was before I brought him to see our Princess Somsawari in Thailand. At that time, his eyes grow. He said, Prapan, tomorrow I will see the mayor of Bangkok. I will tell him to make Bangkok free of AIDS. So that means that at that time, Michel has this ending AIDS in the big cities in his mind already. That's why later on he initiated this Fast Track Cities initiative. I'm very glad that Michel, he asked my dear friend Jose to be his technical arm, or IPAC to be a technical arm in terms of ending HIV/AIDS in the big cities here. IPAC has now done a lot of activities and approaches about fast track cities initiative. So I would like to ask Jose to describe briefly what IPAC has been doing before introducing our first speaker.
Thank you very much, Prapan. I'm thrilled to be moderating this session with you as a clinical key opinion leader for the city of Bangkok. IAPAC and UNAIDS and other partners are hard at work with cities around the world in optimizing care continua through capacity building, stigma elimination in healthcare settings, community engagement work, and as important, the generation of data from which we can derive what exactly needs to be addressed, what gaps need to be addressed across the HIV care continuum. To date, we have been able to launch a number of dashboards that feature data, 90-90-90 and HIV care continuum data, indicating progress or lack thereof across a network of cities. And we're proud to launch 3 such dashboards today, including the Bangkok metropolitan area, Nairobi County, and New Orleans. Our thanks to Dure Technology, the MacAIDS Fund, and Beef Healthcare for their support in launching these dashboards. But beyond the use of data, leadership ultimately is what is driving this initiative. Leadership at the city level, through mayors, through community leaders, through clinical leaders, and an embrace of the idea of attaining not just 90-90-90, but an end of AIDS by 2030. And ultimately, the leadership of my good friend Michel Sidibe, the executive director of UNAIDS, who is visionary not just in the promoting and conceiving of the 90-90-90 targets, but also identifying the need to focus on cities. With that, I'll turn it over to my friend Michel for his remarks.
Thank you very much, Jose. Let me just start by saying that it is about the leadership of all of us. And that's why we're really moving with an inclusive vision. This inclusive vision was about talking about this response in a very holistic manner. Making sure that we can really mobilize a city was for me a key starting point. Before talking about the cities, allow me just to say that the best news of this conference will be the Swaziland result, the result which has been shared by PEPFAR today, showing clearly that Swaziland can already reach 90-90-90, and that Swaziland managed to double the number of people put on treatment in the last 5 years, reduce new infection by 50% during the same period, and showing clearly that producing result should drive all our effort. And reaching the end of AIDS, like you were just mentioning right now, Jose, means getting concrete result also. And getting concrete result, I personally feel, could never happen without also trying to focus on cities as a driving force behind this whole process. For the simple reason that most of the cities, like my brother just mentioned right now, are unfortunately areas where we have innovation, but areas where we have a concentrated epidemic. We have a group of people who are not rich, and group of people who are excluded, but group of people who need to have services. But they can be also the place where we can bring quick transformation. They are hub of innovation. And I personally believe that what we did in 2014 with the mayor of Paris was just a good example to bring few cities together, to have just a political declaration from Paris on making sure that we can scale up 90-90-90 in cities levels has been a breakthrough. Breakthrough because today we have almost more than 200 cities who join this political declaration. More than 75 priority cities are having a major impact on the trajectory of HIV/AIDS infection, and particularly in high-burden countries like Brazil and South Africa. We are seeing already a change happening there in big cities in Brazil and South Africa. UNAIDS is very proud to partner with the city of Paris and IPAC and also UN Habitat in supporting this growing network of fast-track cities. Together we have witnessed a new movement which revitalized the urban AIDS agenda, one of our greatest weapons, like I just mentioned right now, in the fight against HIV/AIDS. Why cities, people will ask clearly. In many countries, cities are home to more than half, I said, of all people living with HIV. Nearly 20% of the whole people living with HIV in France live here in Paris. In Africa, it is the same. Abidjan and N'Djamena comprise about 30% of the national HIV burden. Kinshasa and Yaoundé, about 20%. So social conditions that fuel the epidemic are also found in the cities. Economic disparities, barriers to access to services, social inequalities, and exclusion. It is easy for people at high risk for HIV to hide in cities. I think we need to prioritize differently. We need to make sure that we focused on people who are easily stigmatized, isolated, and ignored. And this is where we can make a major progress in the future. If we want to reach those 80% I was talking about yesterday, 80% of the key population were newly infected. Outside of Africa, we know that 80% of the total new infection are occurring amongst the key population. If we want to reach them, we need to prioritize big cities and key cities where those people are. But cities are also an ideal platform, I can say, for achieving 90-90. It is indeed a platform to implement large-scale interventions, to accelerate the response. Current data center of real-time evidence-based information on what works and what is not working can be built quickly. And it is also a laboratory for new type of public and private partnership and for the engagement of civil society. We need to go fast. And if we want to really break the backbone of this epidemic, we cannot neglect any communities. And in every region of the world, fast-track cities are actively working together to demonstrate that they can be a model of quickening the pace of action. Amsterdam is already there. We'll be hearing from them about how they reach this goal and where they go from here to get close to 100, 100, 100. Melbourne is also in the 90-90-90 club. We will hear from cities closing in on 90-90-90. Paris, San Francisco, Sao Paulo, and Nairobi counties, and how they are assuring the rights of their citizens to access services which no single person will be left behind. And for us, that is the key. And I want to just congratulate all of you, particularly Jose, for your leadership, your commitment, and your effort every single day to make this Paris Declaration a reality and transform our commitment into action for ending AIDS by 2030 by using cities. Thanks for all of you to be with us today. But I want to say again, it is a moment, it is an opportunity, and we need to not miss that window of opportunities we are having today. Thank you.
Thank you very much, Michel. Executing a brilliant vision is a joy, actually, and I think that as we work with cities, they understand, once they realize the importance of closing gaps across the continuum and reaching 90-90-90, that it is the right thing to do. You mentioned the 90-90-90 Club and the need for leadership from everyone. We have on this panel leaders from the cities of Paris, Sao Paulo, Nairobi, Amsterdam, and San Francisco to share their experiences with us in closing the gaps using data and, as important, addressing issues concerning key populations. And we'll start with the Deputy Mayor of Paris. Bernard Jomier is in charge of health, disability, and relations with the Public Assistance Paris Hospitals. He's been an active member of the community since he was 18 years old when he joined Amnesty International France, first as a member of a local group and then as head of his medical committee. later elected to the executive board of the French section of Amnesty in 1995. Mr. Mayor, Deputy Mayor.
Thanks for your invitation. And to start, So to start, let me remind you the French cascade of HIV care. And as you can understand immediately, our main issue is the first 90 target. And of course, our priority, according to this result, our main priority is to focus on testing. Since there is a real too long time from contamination to diagnosis, this time is around 3 years for men having sex with men and around 4 years for other categories of population, particularly concerned by the HIV epidemic. Paris has around 2 million inhabitants, representing 3% of French population. But as Michel Sidibé told you just before, Paris represents 20% of new cases. And two key populations are first MSM, 52% of cases, and migrant, especially coming from sub-Saharan countries that represent 38% of new contamination. So these two categories of population represent 90% of Parisian epidemic. And as we saw, the main challenge is testing, because this time from contamination to discovery is too long, and it's because of this long time that epidemic is still alive in Paris. We have an important healthcare network with public center, GP, community health center, and drugstores. But this network is not enough. We'll see it later. Let me remind you the national framework. As you can see, this framework has changed, but really recently. Self-tests are available in local drugstore from September 2015, and PrEP is authorized since last year. And we changed the national guideline for testing, changed only this year from 1 year to 3 months for MSM, for example. There is now, and it's very important, a consensus on combined prevention. And on the right side of the screen, you can see a public campaign of the National Public Health Agency. It was the first time last November that our National Public Health Agency launched a campaign on combined prevention. So because of this result, with the Mayor of Paris, Anne Hidalgo, we decided to start a new strategy, a fast-track Paris strategy, Vers Paris sans sida. Because of this result, because a very long national commitment to the fight against HIV, despite an efficient healthcare system, despite an universal access to antiretroviral treatment, to free PrEP now, despite this strong consensus, improvements are really too slow, and we cannot accept it. So the philosophy of our strategy is first of all evidence-based, and scientific evidence-based, of course. We want to recognize the diversity of our population, no stigmatization, no discrimination, and we prioritize the key population in our public health program. 3 main goals. 1, to develop, scale up combined prevention. Second, the PrEP, disseminate access to PrEP, and by now around 1,500 MSM access to PrEP in Paris, and of course the objective is around 7,000 people. And all of this in an inclusive approach of our population. This year, we started some new programs. You have the list of this program here, and some other like the campaign to promote self-esteem and fight stigma are to start next year. So we launched a new citywide campaign named Faisons l'amour, Make Love, and Make Paris the City of Love, free of AIDS. This campaign has a triple objective. First, involves the general population, because as mayor and deputy mayor, we have to talk to our population to make our population comprehensive with our public health objective. Second, make the key population visible. MSM, trans women, black men and women particularly concerned by the epidemic. And three, disseminate new messages like PrEP, TASP, repeat testing and self-testing. So you can see this campaign. Anne Hidalgo and Michel Sidibé and Dr. Zonega, I saw this morning, participate in this campaign by taking a picture in booth 216. You can participate in our campaign and support our political will to reach this club, the 390 club, with other cities. But to conclude, I want to tell you that many challenges are ahead of us. We cannot afford self-satisfaction because we are still far from getting to zero. And I'm convinced that the last 310 will be the hardest. And to tackle these last challenges of ending AIDS, we need a strong FTC network. We need to work about other cities, not only to share data management, but to share difficulties, questions, and solutions. I'm convinced that cities are a pertinent scale because mayor and elected council are close to the community's needs and actors. And that's the reason why this morning the mayor of Paris signs the Paris Community Declaration, because to win this fight, we need to be together, of course, scientific and research community, NGOs community, and political leaders to end this epidemic and to end with this epidemic social discrimination and inequality. Thank you very much for your attention.
Thank you very much, Deputy Mayor. I should note that Michel had to leave for another meeting, but we're honored to have with us our friend Luis Loures, who's the Distinguished Deputy Director of UNAIDS, and will make some remarks at the close of the session. Our next speaker is Dr. Esper Calles, who's an infectious diseases specialist and a professor of medicine at the Division of Clinical Immunology and Allergy at the University of Sao Paulo, Brazil. He served as a member of the HIV Vaccine Committee and the Therapy Committee for the HIV/AIDS program from the Brazilian Ministry of Health. Dr. Calles coordinates a clinical site that has conducted key clinical trials such as STEP and the IPREX trials. Dr. Calles.
Thank you, Jose. Thank you. So to start, I would like to say I have no conflicts of interest to declare. And the second thing is I'm a simple physician. So my task is basically take care of patients and do some research at the institution I work at in the University of Sao Paulo. So perhaps the best people to be here today would be the people who take care of the public policies in the city and the state. I understand we are in a transition period from one administration to another, so hopefully next year they will replace me and present you with more in-depth interventions that are ongoing in the city. So because nobody knows Brazil, this is our country, it's a huge continental country. I would point out to you all that São Paulo is located in the southeast, where the economic and population concentration happens most. So this is a big country, fifth in the world in land extension, in population, seventh economy and going down. The inequality is high, unfortunately, and we still have a seventh place of GDP ranking in the world. But really, if you want to know where the population concentrates in Brazil, just go to the beach. So if you compare those two maps, you see how the population is mostly concentrated on the coastline, especially in Southeast, where you have two very familiar states to you all, São Paulo and Rio de Janeiro. And the epidemic follows the same trend, where you have more big cities along the coastline, but also a few distributed inland. So we've been distracted, and it's very hard to maintain attention to this epidemic going on in Brazil with all the things that we've been facing, including the tragic events in the World Cup, followed by the Zika epidemic, and then the recent yellow fever outbreak and some difficulties we're having in our political scenario. So it's been a struggle to maintain everybody aware of how this epidemic is hitting our, not only the world, but also our country. It's a very interesting point to present is that the population is growing old. As the natality rate has fallen to less than 2 children per woman, the pyramid in Brazil is shrinking in the bottom, in the base, so the population is aging with time, and this has been documented throughout the country, but especially in the most populated areas. How about our epidemic? So we have estimated almost 800,000 people living with HIV/AIDS. It represents about 0.43% of the general population, and 0.58% is estimated to live with HIV/AIDS in the youngest population from 15 to 49 years old. And fortunately, since '97, the country has adopted a very aggressive policy to provide antiretroviral therapy to those living with HIV, and which reached out to about almost 500,000 people taking antiretroviral therapy. That led to a decrease in mortality seen after introduction of the antiretroviral therapy as a combined approach to treat 8 people living with HIV/AIDS, but this has been maintained throughout the several years. So if we focus to what happens in São Paulo, reflects mostly what we see in the big cities across the country, which is a concentrated epidemic that's very similar to what you see, for example, in the United States and Europe, where you see a concentrated distribution in heterosexual men, followed by MSMs, and then the IV drug users. That has been changing throughout the years. As you can see, comparing 2002, 7, and 12, this is data provided by the state of São Paulo. We see an increase, unfortunately, in the group of MSMs, especially in the big cities such as São Paulo and Rio. So we need to focus to increase the strategies, especially in this group of people. Well, after Brazil adopted and signed up the goal agreed in Mexico of 90-90-90, we've been working, the government at all levels have been working to reach and obtain data, adapted the system, and obtain all the information to understand what is this cascade going on in Brazil. And we adopt a system called the Logistic Control System for Antiretroviral Delivery, and that's called CICLOM in Portuguese. And basically, it provides the information not only if the individual is being delivered the drugs at the pharmacies throughout the country, but also informs what is the components of that regimen and the last virus load result that is obtained separated in strata. In São Paulo state and the city of São Paulo, there is an alert system for every person living with HIV/AIDS who does not come for another delivery after 7 days of expiration date. And any missing appointments is put to the system, brought to attention to those caring for those individuals. And those are considered lost to follow-up if they have no drug delivered after 3 months or no follow-up visits after 6 months. With that, we can construct the cascade. And this is what we see. So we are doing quite well in the two extremes of the cascade, where you see estimated 87% of people living with HIV/AIDS who have the diagnosis, 91% of those on antiretroviral therapy who have virus load under 1,000 copies, but we're still having some to work more and improve the second step, which is those diagnosed going on antiretroviral therapy, and I'll comment on that in a bit. So for diagnosis, this has been a major focus in all government levels to provide the necessary tools and access for diagnosis. So what you can see here, there are several. We adopted rapid tests in the testing sites. There are campaigns focused on being tested. This is the campaign carried on in São Paulo state. This is a campaign that's going on right now at São Paulo City by the city system to free testing on Sundays in a leisure area in São Paulo, in some parks. We have a special campaign to test all pregnant women, and the PEP program has been implemented since 2013 as one way to bring people and link them to care. Now, in regard to antiretroviral therapy, we have an integrated approach with country level, state level, city level, and private sector. The São Paulo city only has 26 sites. Imagine an 18 million metropolitan area population needs to be served in several points of care where they can be tested for HIV or infectious sexual transmitted diseases, in 16 clinics to provide PEP, antiretroviral therapy, treatment of other ISTs, and viral hepatitis. So new approaches to close the gaps are coming along. The first, and it's very important, has been adopted since February, the access to integrase inhibitors as a first-line therapy for those diagnosed with HIV, which decreases the amount of side effects provided by the antiretroviral therapy. It facilitates intake, and it makes easier for patients to tolerate treatment. And finally, the good news that came very recently, like a month ago, Brazil has adopted PrEP and approved as a public policy to prevent HIV transmission. This program is in its implementation phase, where we expect in the first phase to start at least 6,000 people taking PrEP throughout the country, but mostly in big cities such as São Paulo. And finally, work on information and spread the idea of how HIV/AIDS epidemic is important, trying to bring the attention of the population to this very important subject in the diversity which is this country. I'd like to finalize thanking the Maria Cristina Abate and Caritas Basso, who are those running the city system on regarding HIV/AIDS program, and Maria Clara Gene and Arthur Kalishman, who represents and run the state program, and our research team at the University of São Paulo. Thank you.
Thank you very much, Dr. Carlos. After hearing the experience from Paris, Sao Paulo, now we come to Nairobi. Nairobi will be presented by Dr. Thomas Orago, Thomas Orago is a public health physician, and he's now the Director of Health Services in Nairobi City County and in Kenya. Dr. Orago, please.
Thank you. Nairobi City is in Kenya, as you know. That's my outline of presentation. That's the aerial view of the city of Nairobi. Just a background, Kenya has a population of about 44 million, and 10% of them stay in Nairobi City. If you look at the number of people living with HIV/AIDS, out of the 1.5 million Kenyans living with HIV/AIDS, 11.3% of them stay in the city of Nairobi. However, if you look at the new infections, only 4% of the new infections in Kenya come from the city of Nairobi. In terms of mother-to-child transmission, overall, Nairobi City has achieved less than 5% transmission rate, which is lower than the national average. We record only about 2,400 cases of deaths due to HIV/AIDS compared to the national level, which is about 30,000 deaths. That map shows a snapshot of the HIV prevalence across the 47 counties of Nairobi, of Kenya. If you look at Nairobi, is 6.1%, and the highest is about 26% around the Lake region, and Nairobi is number 9 among the 47 counties. Now, in terms of key population estimates, this looks like a slide, but we have about 6,000 injection drug users in Nairobi, about 29,000 female sex workers, and about 10,000 men having sex with men. And of course, the transmission rate is very high among this key population, and being highest among the female sex workers. What was our roadmap in terms of fast-tracking the HIV in cities? One was to scale up what was working, mainly HIV testing, ARV provision, prevention messages among key populations, and of course, elimination of mother-to-child transmission services. Also, the new ways for delivering programs, especially integrating heart activities in MCH, increase access to HIV treatment facilities, and of course, making sure that we test all those who are on ARVs. Of course, collecting data and also management and coordination of the financing activities within the city of Nairobi. This is our HIV cascade. If you look at the left side, this one is among the pediatric patients. We have about 8,203 children living with HIV/AIDS, but we have managed to get 7,370, our 90%. Our viral suppression is only 50%. That is what we are trying to improve. If you look at adults, that's adults more than 15 years of age, 163,000 living with HIV/AIDS, and we have managed to only capture 125,000, that's 77%, our first 90. Our last 90 virus suppression rate is slightly lower, only 55%. This overall, our virus suppression rate is about 55% out of the 171,000 estimated number of HIV positive patients. Well, these are basically our progress since 2014. If you look at our first 90, we have improved from 60% to 77%. Among those ones on ARV, we have improved from 79% to 96%, which is an increase of about 17%. Where we have done well is HIV suppression, where we have moved from 12% to 55%, which is a very large increase of 43%. Well, how have we done it? We have increased the number of ARV sites from 169 to 189, and of course the EMTC sites from 180 to 302%. Also, we have done well in infant prophylaxis from 52% to 95%, maternal prophylaxis from 72 to 94%. We have also improved in TB HIV collaboration because we have improved the number of co-infection patients on ARP of co-infection from 80 to 88%. How have we done it? If you look at that picture, it shows HIV messaging. On your right side is our public transport system. It is carrying a message on HIV. And in this case, we actually got an award from the First Lady. If you look at the First Lady, that's the First Lady giving us an award, plus our Minister for Health, because of doing very well in terms of HIV messaging, because our transport system, there's very many messages informing the residents of Nairobi about HIV/AIDS. We have also done well in terms of leadership and governance. If you look at that on your right side, that's the top leadership of the Nairobi City government. We have also developed our county aid strike plan, which is in use. We do very well also in terms of partnership. As you can see the right side there, that's a partnership meeting that's going on in Nairobi. In terms of elimination of mother-to-child transmission, as I said earlier, we have done very well because our HIV transmission rate from mother to child is less than 5%, which is 4.7%, and we received an award for the same of that. In terms of other services, especially key populations, we have increased the number of facilities offering methadone-assisted therapy. This is our newly constructed facility, which is offering methadone-assisted therapy towards the key populations. We have also done very well in terms of data management. We conduct quarterly management, and biannual data review meetings. We are scaling up electronic medical records for HIV services, and I think, as you have heard, Nairobi was one of the cities that launched the HIV dashboard today. We have done well also in terms of laboratory strengthening, in terms of improved linkage, so that we can be able to get results in time. Our laboratories are underway accreditation, and also our laboratories are connected to the external quality assurance systems. We also conduct regular updates and trainings, especially for HIV testing and counseling policy guidelines, which are given by the national government. We also do HIV testing and prevention services. We conduct HIV testing outreaches for the unreached ones. We have also rolled out the HIV testing, self-HIV testing, which was launched recently, and Nairobi is one of the counties that has rolled out since May. For pre-exposure prophylaxis, we have rolled out up to 47 facilities in Nairobi, and we have so far about 20 surgeons trained in terms of voluntary medical male circumcision, which has also scaled up. Nairobi, we are also focused on Kenya Fast Track plan for HIV/AIDS for adolescents, so that we can be able to have our young girls to access the services. The number of facilities offering friendly adolescent services has also increased. We have 6 public and 6 private. We have also developed youth initiatives. There's what we call in our local language, there's a Sauti Sikika for the adolescent youth in Nairobi. We collaborate very well with the other sectors, especially the Ministry of Education, where you find these young girls, and also mobilize resources so that we can also inform about the risk of transmission of HIV. We have a few challenges, the most common one being the highly mobile population in Nairobi. As you know, Nairobi is the capital city of Kenya, so we have a high mobile population because they come and go. We have also some gaps on data management, especially quality, and the low uptake of electronic medical records. About 6% of the population of Nairobi, they seek health services in the private sector, both formal and informal. So you find there is high turnover of healthcare workers, which affects quality, and also the poor quality of reports in terms of completeness and timeliness because of the high number of informal private sector. Stigma still persists, particularly the growing numbers of key populations in Nairobi. Providing quality services for the adolescents, for example, issues of access, those are adjustments for children, and sometimes disclosure because these are minors. Sometimes, occasionally, because of procurement issues, sometimes we have some stockouts of the HIV test kits, and therefore now we cannot, some of them cannot be able to access. These are our key priorities for 2017-2018. Of course, we target at increasing, continued and increasing testing services, increase the number of HIV treatment sites, and we sustain those ones who are there. Of course, continued engagement with the private sector, which we are doing, and the scaling up of the voluntary medical male circumcision sites. We have 20 sites. We are training more surgeons. We continue scaling up the adolescent services, especially in the peer groups. Strengthening of TB-HIV collaboration. You see we have reached at least 90% HIV people living with HIV and TB on ART. Scaling up of the medical records, data quality audits, and continued data review meetings. And as you have heard, we have just launched our dashboard. Of course, results, to improve results on turnaround time, especially from the viral load testing. Continuous scale up of pre-exposure prophylaxis, and strengthening more methadone-assisted treatment therapy services. Continually capacity building our healthcare workers in form of CMEs, and of course the use of partner reporting website, and of course continue the strength of the EMTC program. Thank you very much.
Thank you very much, Dr. Orago. Now we move from the south to the north. We'll come to the Amsterdam. Dr. Maria Prince, she's a professor of public health and epidemiology of infectious diseases at the Academic Medical Center in Amsterdam. The reason that she's here, because she's the head of the Department of Infectious Diseases Research and Prevention at the Public Health Service of the Municipality of Amsterdam. So she's going to tell us about the experience in Amsterdam. Please.
Good afternoon. Thank you for a very nice introduction and for inviting me to present to you Amsterdam's approach in reaching 1990. I have no conflict of interest related to this talk. And before I will go to our current strategy in fighting the epidemic, I would like to go back to the early epidemic, because I believe that some of the major components in our system are still very important in what we have reached today. So, when HIV arrived in our city, there was already a heroin epidemic going on, like in many high-income countries. But at that time, the city responded with programs with high coverage of harm reduction programs that included opiate substitution therapy, methadone, integrated in a larger approach to address drug dependence and drug use. And with this approach, the city reached 70% of all drug users in the city. And that has been very successful, and almost for more than 1 decade, we hardly see any new infection of HIV, but also of hepatitis C in this population. What's also important is that the Netherlands and also Amsterdam has a very inclusive climate for all residents and key population. We, the public health service, we are part of the municipality, and we serve all people and have special attention for those who might need a little bit more help in promoting their health. That's also what is quoted on the Fast Track City website, that inclusivity is essential to stop the urban HIV epidemic. That's the quote of our mayor of Amsterdam, Van der Laan, who signed the Fast Track City statement a few years ago. Also, from the beginning onwards, we have free HIV and STI testing at low threshold sexual health clinic, and we have universal health coverage for the primary care delivered by the general practitioners, who are the major persons who do the testing for HIV. And also we have the specialized care at very well-trained and professional HIV treatment centers. They are covered by our health system. What also is essential that we have very good data, and that means that it makes it more easy to design your programs. This is the Netherlands, and the blue dot in the middle shows the number of individuals living with HIV infection, and that in the middle of the blue dot is Amsterdam, the Amsterdam region. In Amsterdam, we have less than 1 million inhabitants, but we face the highest prevalence. And typical of the Dutch and the Amsterdam's approach is that we involve all partners in our programs, and that was already at the beginning of the epidemic. This is a statement in Dutch, so don't try to read, saying at the beginning of the epidemic that we are going to start prevention programs, communication and research, but it's important, it's already mentioning that in those activities there's fully engagement of the community. So you might think we have an ideal infrastructure. However, even in this infrastructure in this city, we face new HIV diagnoses each year. In the total of the Netherlands, it's around 1,000. In Amsterdam, it's 1/3. And we observed a drop in the number of newly diagnosed individuals, and that's now below 200. However, we have still late diagnosis. The proportion that's presented late for care among the MSM is 36%, and on migrants, on residents that originate from countries with high prevalence is even 53%. And we have ongoing HIV transmission in men who have sex with men, and that's prevalent. That's the case for all age groups. So this ongoing transmission was the reason that we were sitting together again, and that we designed and launched the AIDS team, HIV Transmission Elimination Amsterdam. We are joining forces for a future with no new HIV infection, and of course we also promote the health of those living in our city with HIV infection. So what did we do? We sit together and look to the Amsterdam continuum of care, which indeed now have reached 94, 19 and 94. But there is still room for improvement. So for the population at risk, at the time we started the AIDS team in 2014, there was not yet PrEP available in Europe and not in Amsterdam. We also tried to accelerate early diagnosis by communication strategies and accelerated testing. And we focused on barriers for treatment and on the viral immunological studies in acute HIV infection. In more detail, what did we do? We started a PrEP project for men having sex with men and transgender people at high risk for HIV infection. We all know that though that PrEP is effective, and we just running a demonstration project in which people can choose themselves between daily or event-driven or on-demand PrEP, and we are following what's happening. And so far, we haven't hardly seen any new infection among those men in our PrEP project. To improve testing and early diagnosis, we started a campaign to promote the recognition of acute HIV infection. We have a website where people can go if they think they are at risk of IS. They fill in our questions about acute HIV infection in combination with risk behavior, and they get an advice from a rapid test trajectory at the Public Health Service with same-day referral. And this project is very successful. Of the people who are tested through the project, 9% is HIV infected, and most of them are still in the acute phase, so we get them really, really early. As you have seen, late diagnosis among ethnic minority is a major issue, and most of them are seen by general practitioners for several reasons, for example, for diabetes. And we try, via special programs and training, to scale up provider-initiated testing, and we also have focus on community-based testing. We studied the barriers regarding treatment, not only among the patients, but also among the HIV physicians, and we used the outcomes to improve early treatment uptake. And finally, we did some research on the viral reservoir and immune system and the effect of immediate treatment. So we are now in the phase of the second phase, and we try to start new projects, but I would like to end with the lessons learned so far. We knew that closing working together with all stakeholders works and is great, but also has some challenges. I think the way forward is to identify your gaps in the prevention care, and really it is important that you start innovative projects and pilots that are feasible and preferably integrated in existing intervention, because that will promote efficiency and implementation afterwards. So we use our outcomes from the projects for adjustment and implementation of those services in routine HIV prevention and care. Secondly, political and community leadership and commitment at the city level are key in our success. We also learned that 1990, because we started before we reached those targets, is not sufficient to stop ongoing transmission. So we go now for the last mile on the road to zero new infection, and that poses the biggest challenges, because we try to get in contact with the difficult to reach and underserved populations in our city that are not aware of their HIV infection. And importantly, we will try to motivate them to test, engage in care, and start treatment, taking their needs into account. We will optimize our comprehensive prevention programs and their uptake. And also important in having a city or regional approach is to be ambitious, continuously try to innovate. Amsterdam goes now for 100, 100, 100 and zero new infections. And we are happy to share with you our success and our failures. And we hope we can have a proof of principle very soon, demonstrating that we really can have zero new infections in the city. Finally, I would like to acknowledge Joep Lange, who passed away on his flight to Melbourne in 2014. He was the founder of the HIV team. I would also like to acknowledge all partners, and in particular Pieter Rijs, who is the project leader of the AIDS team, and Golieve de Brey, who is the project coordinator of the team, and my own team at the Public Health Service. And I also would like to thank the funders, and I would like to thank you, and I hope to see you all in Amsterdam in 2018 at the conference.
Thank you very much, Dr. Prince. Our last speaker is well known to many of us here. We saw her in many stages, talking about HIV vaccine, talking about PrEP, and now she's talking about ending AIDS in San Francisco. Dr. Susan Buchbinder, she's director of the HIV research section of San Francisco Department of Public Health, and she will talk to us about the experience in San Francisco.
Thank you so much. It's wonderful to be here, and I'm speaking on behalf of the entire San Francisco Getting to Zero Consortium. These are my conflicts. So I'm going to start the story in 2013, which actually predates our Getting to Zero Consortium, to show you that we were already experiencing declines in new HIV diagnoses and death. And we think that's because of a number of programs that we had started, including trying to remove barriers to HIV testing, offering ART regardless of CD4 count and scaling up testing at both community centers and clinics, linking people through navigators both into care upon a diagnosis as well as relinking them when they dropped out of care, starting a PrEP demonstration project just a few months after PrEP was licensed in the United States, and a pilot project at San Francisco General Hospital to offer same-day antiretroviral treatment. So it seemed that all was well, and we were presenting on these and new innovations at our annual Community World AIDS Day Forum, and asked for input from the community when a very astute community member said, well, this is great, but are you actually working together? We realized we really weren't in a fundamental way, and so we launched the Getting to Zero Consortium, which is a multi-sector consortium operating under the principles of collective impact, which is the commitment of people from different sectors of society to address a specific problem by coming around a common agenda. This is just a subsample of the many organizations that we have who are working with us, and we have over 200 volunteers who are part of our effort. We have foundations working with us. We have community-based non-governmental organizations, clinicians, research groups, as well as the Fast Track Cities initiative. So we started by defining 3 strategic priorities, having a coordinated city PrEP program, a citywide PrEP program, same-day offer of antiretroviral treatment and comprehensive services, linkage and re-engagement in care, and then added more recently an anti-stigma group initiative, as well as we're just in the process of forming an initiative to focus on adolescents and young adults. But none of these programs would really be possible were they not built upon this foundation of comprehensive, both medical and psychosocial care for a wide variety of people, both at risk for and living with HIV infection. And so around each of these strategic priorities, a committee is formed of volunteers. They've developed a prioritized action plan, metrics, and milestones. And what drives the work of each of these committees are the data. So where are we as of the end of 2015? What you can see in the green line is that we think we are starting to turn the trajectory of new diagnoses that seem to be declining more rapidly. People are surviving longer, so we now have 60% of people living with HIV in San Francisco who are over the age of 50, which requires additional layer of services, and our late diagnoses have declined to 16%. Our 90-90-90 numbers are shown here. We're most confident with the first and last 90 because the first one is based on a population-based annual survey that includes HIV testing, and the last one is based on reported viral load testing, and viral loads are mandatory to be reported to the state. The middle number is the one that we have the most difficulty with, and listening to some of these other cities, it's clear that we really suffer from having a fractured healthcare system in the United States. And so the way that we estimate the number of people on ART is to first take everyone who has been diagnosed with San Francisco as a San Francisco resident, who hasn't died or moved away, and using that denominator, we count the proportion in care as the group, the proportion who have had any viral load testing as of in the year 2015, and then we multiply that by the proportion of those individuals who we believe have ever been on ART based on chart review, but that's the best we can do for our middle 90. And so that makes it difficult to compare across cities, particularly in the United States. So I urge you to look at the fine print, which fortunately the Fast Track Cities initiative has on their website so that you can understand how different cities are arriving at those estimates. So our committees are focused on addressing all of San Francisco, not just this component of San Francisco, but also this very real component of San Francisco, and a focus right now on disparities in particular. And we have disparities. These are the number of new diagnoses per 100,000 population in men in San Francisco, looking at race, ethnicity, and you can see that although the rates of new diagnoses have declined over the last several years in African Americans, in Latinos, and in white men, there are still racial and ethnic disparities. And if you look at women, who make up only 8% of our new diagnoses are in cis women and 2% in trans women, you can see that the scale is different, but we still have disparities, particularly for African American women. So first let me describe the PrEP group, because they immediately formed into 3 sub-working groups. One working on increasing capacity for providers to provide PrEP, one working on potential users of PrEP to increase knowledge, access, and demand for PrEP, and a third focused on metrics so that we could measure what we're actually doing with PrEP. These are initial estimates of the numbers on PrEP in 2014 and 2016, and we estimate that we've more than doubled the number of people on PrEP over that period of time. But again, if you look at disparities, these are broken down by different racial and ethnic groups, and you can see as a proportion of the group that we believe would be eligible for PrEP, that in 2014 we were largely reaching white men who have sex with men. And although by 2016 we've improved those rates within each of the racial and ethnic groups, we still have substantial disparities. And so very recently the city awarded 4 grants to individual non-governmental organizations to work specifically with African Americans, Latinos, transgender women, and youth. And we've launched a novel pharmacy-based project in the Mission District, which serves a largely Latino population, so that people can just go to their pharmacy to get PrEP without actually having to see a provider. Our second group is focused on rapid access, so same-day linkage to comprehensive services as well as antiretroviral treatment. And that really initiates a conversation between providers and patients about the benefits of starting ART. Many of them do start same day, and it's because of all of these benefits that accrue from early treatment, but also we've learned from our patients that it's often empowered them to disclose their HIV status to their friends and family, in part because they're doing something active to deal with their infection. We have a protocol on our website that you're welcome to download that we're using to go out and train providers in a variety of settings, and those who are not able to do same-day antiretroviral treatment and comprehensive services send their patients by taxi over to one of our treatment hubs. So this is what we've done from 2013 to 2015 in terms of the time from diagnosis to care is a week, care to ART initiation is now less than a week, and from initial diagnosis to viral suppression is approximately 2.5 months. Retention is actually our biggest challenge in our treatment cascade, and this is the cascade of people who were virally suppressed in 2014. If we remove people from the denominator who we know have moved, we're estimating that 72% of them have both had a viral load in 2014 and their last viral load was suppressed. And so the retention group is working on enhancing this linkage program that we've had for a long time, but expanding it to be citywide, embedding retention specialists in our clinics that serve particularly our most vulnerable populations. We have an intensive case management program specifically for our most vulnerable populations to link them to a wide variety of city services. And we know that we need to address all of these other issues, and we're starting to try to address them because they interfere with people's ability to care for themselves and their HIV. Our anti-stigma and discrimination group is focused first on broadening the measurements of stigma in our city for both positive and negative persons, and then we're starting with trainings in providers, particularly outside of primary care where people may be less familiar with the populations with whom we work. So people often ask us, what's the special sauce to getting to Zero San Francisco? And what I would say is that I think that it's that we've got this multi-sector collaboration of activists, clinicians. Our health department and mayor have been critical, researchers, foundations, and many others. We all have this passion for the same outcomes: 0 new infections, 0 HIV deaths, and 0 stigma. We're focused so much on the data, and we're continuously trying to learn and improve what we're doing. And I've already learned quite a bit from the other cities who presented today. And so we are working with cities in the general Bay Area to try to improve what we're doing and share best practices with them. We're working with Fast Track Cities initiative that's linked us with a number of cities, and we're now working with individual cities on 5 different continents. And so I'm going to end by thanking the entire consortium and the steering committee, who are all volunteers, our surveillance unit, without which we couldn't be doing this work because we wouldn't have these great measures, our Director of Health, our Mayor, Board of Supervisors, and many individuals, including Diane Havler, who's got a competing session right now. So I just want to say that we're happy to share all of the materials that we've developed on our website. Please go to it and download whatever you can. We're in the process of revamping it. But we also really want to learn from you. So please, if you have ideas and thoughts, send them to us at this email address. And thank you very much for your attention.